My name is Helena Obermair, editorial fellow with the International Journal of Gynecological Cancer.
And my name is Shushkevich, current EEG member in IGA. Today with us is Professor Philipp Harter, SN Clinic. Thank you so much for joining us, Professor. We already prepared a 4 question for you regarding your previous talk, and this is a great pleasure that you find time for us today. Thank you.
Yeah, thank you for the invitation.
So for the first question, what is the role of molecular profiling on lymph node staging in endometrial cancer? Is there evidence for omission of sentinel lymph node biopsy in POLE-mutated or MSI-H tumours, or for full lymphadenectomy in P53 tumours?
I think this is a very interesting question. Unfortunately, the literature is really limited regarding the role of lymph node metastasis and the adequate surgical approach, especially what is the role of lymphadenectomy. However, we have already some good publications with several hundreds of patients, and you are right, P53 abnormal. This is the most problematic tumor with the highest rate of lymph node metastasis. And also, I think very interesting, there is more or less no difference between the MMR deficient population and the NSMP population. This is more or less similar. POLE-E, we don't know. The data about lymph node metastasis in POLE-E tumors are very, very rare. But however, also lymph node metastasis in POLE-E positive patients are reported, and I think as a central lymphadenectomy, it's a diagnostic step. So if you have lymph node metastasis, bulky nodes, then you have to remove it. But this is not a sentinel. And if you remove bulky nodes, it's irrespective of the tumor type. But just for the sentinel, it just indicates you the need of adjuvant therapy. So therefore, if you have a good visibility of the sentinel node, I think this is sufficient. But you are right. This is a big question if the sentinel lymph node technique fails. And then, even if we look for all the other criteria, so if you talk to patients, I know there are some data about, for example, patients with vulvar cancer, where the lymphadenectomy has much more impact on quality of life compared to endometrial cancer. And if you ask patients, most of them say if the risk is 5% or something in this region, then they would like to have a lymphadenectomy. But however, I think also we have to keep in mind, if you have completely negative lymph nodes and you know already that the treatment is defined by the molecular subtype, so the question is, do we need to make it or not? But however, I think the central lymph node methodology, if you're all doing this now since several years and the detection rates are more than 90-95%, is not comparable to 50%, what was in the beginning, so therefore I think it's very rare situation that this technique fails, and more often you have additional patient characteristics. Let's say, okay, 85 years old or BMI is 50 plus, and this is more defining your surgical strategy than the central technique alone.
Thank you so much. My first question, our second question is regarding fertility sparing surgery. And what is your opinion? Would molecular profile in endometrial cancer help us to select right patients?
Yes, I think for the fertility sparing therapy, in the past we focused more on endometrioid, low grade, but however it was not really ever clearly defined. So nowadays we have more and more data, we are more aware of the MMRD status. However, I think it's also an important question, is it just MMR or is it really syndrome? But if you look for the response rate, we have the best response rate in the NSMP population, but also MMRD and P53, the response rates are not very promising, so therefore I think you have to counsel the patients adequately. And even if it is successful, in especially the last 2 subgroups, you also have a high risk for relapse. So therefore I think we have to be aware that P53 abnormal, MMRD are not foresee the ideal candidates. Maybe it's more the endometrial patient population. However, I would recommend also to look for the classical criteria in addition, ER status, PR status, and then you can define if this is a good patient or not.
And on the same vein, how would that translate to ovarian preservation? Can we use molecular profiling to determine who would be eligible for ovarian preservation in endometrial cancer?
Short answer, no. No, but I think this is a very important topic. We see more and more younger patients also with endometrial cancer, and therefore I think it's a very important question if we could spare at least the ovarian function, that they don't become all postmenopausal directly after surgery, which has a huge impact on quality of life. So the molecular classification itself, again, MMRD, P53 abnormal, is patient population with the highest risk. We also have to keep in mind that there are also more than enough classical factors like grade, LVSI, which are important for lymph node metastasis. There are also some publications identifying vitamin B as additional risk factors. So I think it's a very interesting topic, but so far molecular classification cannot completely answer how could we select the patients. It's a mixture of old classification and the new classification, and if both looks good, then you can feel better. Okay?
Yeah, thank you so much. Very interesting. If we have this opportunity to test patient, I mean, young patient, of course, this is not like worldwide that there is a country with lack of. Yeah, but if we have this, should we test and should we make molecular profiling, like without any doubts? I mean, for each patient. First of all, when we think about, for example, ovarian preservation or so on.
I think you should at least, so if you want to know the histologic subtype, most patients you know the steroid receptor status. I think P53 is immunohistochemistry is also standard, MMR status immunohistochemistry is also a standard. I think the standard is available in most countries, but I absolutely agree. For example, POLE-E is more difficult and maybe not available, but so far we don't have data about ovarian preservation and what is the role of POLE-E. So therefore, for this question at the moment, it's not indicated.
Thank you, Professor.
And finally, what do you think are the most urgently needed studies in this area and in the area of molecular subtypes of endometrial cancers, and what would a study like that look like?
Oh, there are several questions. No, I think at the moment we have identified P53 as a certain subpopulation. We have identified the MMRD population, POLE-E also, but this is rare. NSMVP is a mixture of several characteristics of the tumor, and now we have the discussion, should we still call it NSMP or non-MMRD, and I'm sure if we invest further time and look more for molecular changes, we also will have further division of this subgroup and several other subgroups, which makes it not easier for all of us. However, I think also very interesting are all the surgical questions. So, because all the molecular subgroups are so far validated or evaluated, if you discuss adjuvant therapy after surgery or if you discuss systemic therapy for relapse, but all the surgical questions are still open. What is really the role of the molecular classifications? This is undefined, and I think because you can have the molecular profile by curettage, you know it before you go to surgery, so therefore I think it will also be an option maybe to modify your surgery or to better define what is really needed.
Excellent.
Thank you so much. Thank you so much for your answer, Professor. It's a big pleasure for us to make this interview today. Thank you for being with us today.
Thank you.